So,
Yeah.
jetzt, ja. Thank you.
Okay. So right ventricular apical pacing has been well established for more than 60 years. Modern cardiac pacemakers guarantee stable electrical stimulation for years and reliably prevent asystoles. In case total free block, dual chamber pacemakers also restore synchrony between atrium and ventricle, as shown in the slide below with atrial sensed and atrial paced. Nevertheless, right ventricular apical stimulation does not restore the physiological excitation of the heart, but turns it upside down. It is comparable to ventricular arrhythmias from the apex and the left bundle branch block. While some of the patients survive this non-physiological stimulation for years without damage, other patients deliver pacemaker-induced cardiomyopathy. These observations are the starting point for the search of alternative stimulation sites. Kurshid retrospective studied 1,750 consecutive patients undergoing pacemaker implantation between 2003 and 2012. Patients were included if baseline LVEF was normal, single chamber ventricular or dual chamber pacemaker was implanted, and frequent more than 20% RV pacing was present. The pacemaker-induced cardiomyopathy was defined as a more than 10% decrease in ejection fraction, resulting in an ejection fraction of less than 50%. Of 257 patients, 20% developed pacemaker-induced cardiomyopathy with a decrease of the ejection fraction from 62% to 36% at a follow-up time of 3.3 years. The Danish national-wide registries included all patients without a known history of heart failure who had a pacemaker implanted with right ventricular electrode between 2000 and 2014, and that was 27,000 patients. An age and gender-matched control cohort of 138,000 patients without pacemaker and heart failure was identified to compare the risk. Outcome was a cumulative incidence of heart failure and all-cause mortality. And you see that in the pacemaker group, there is a higher incidence of heart failure than in the control match group. Therefore, the search of alternative stimulation sites is as old as pacemaker therapy. The figure of Arnold illustrates the current landscape of terminology and anatomy of conduction system pacing. Let's start with the most established type of an alternative stimulation, the biventricular CRT. That's here. And we do this together with the right ventricular septal stimulation. In the first randomized controlled trial with CRT and endocardial stimulation, we placed the LV electrode in a posteroceptal position and the high ventricular electrode in a midseptal position. The reason was to achieve the longest possible interventricular delay and thus an optimal resynchronization. Before large endpoint studies, we were able to demonstrate a benefit in clinical parameters. In a more recent electrophysiological study we have shown that the interventricular conduction delay is longer with the septal position of the EV electrode. So that seems the best position for biventricular resynchronization therapy to have one electrode in the posterolateral position and the right ventricular electrode in a mid-septal position. Irgendjemand hat sein Mikro an. Somebody has opened his microphone. Left ventricular bundle branch block leads to a mechanical dyssynchrony with shortening filling time, increased mitral regurgitation, reduced ejection fraction, and neurohumeral activation. With CRT, we can treat the left bundle branch block induced cardiomyopathy. As you see here, the synchronous contraction is achieved immediately with the biventricular stimulation. The prognostic effect of CRT could be demonstrated in a number of CRTs with more than 10,000 patients. The studies showed an improvement in functional capacity, symptoms, and LV function, but also a reduction in heart failure hospitalization and all-cause mortality. The long-term follow-up of the MEDIT CRT trial shows a highly significant effect on mortality in patients with left bundle branch block with a risk reduction of 41%. On the other side, patients without left bundle branch block showed under CRT an increase of mortality in 57%. Deriving from these studies, the guidelines give us a recommendation with strong evidence. This includes patients with left bundle branch morphology and a class 1 indication if the QAS complex is more than 150 milliseconds. There's only an 2A indication when the QAS morphology is below 150, between 100 and it must be 130 to 150 milliseconds. On the other hand, patients with a QAS width of more than a patient with a non-left bundle branch morphology, there's only, with exception of the patient with a QAF width of more than 150 milliseconds, there's only an unclear evidence for the other indications. This applies to patients with, also for patients with permanent atrial fibrillation and to patients with a pacemaker implantation. %50 of the electrophysiologists prefer a septal position of the AR electrodes. The results are conflicting with a slightly tendency in favor of septal stimulation. Here we have a typical example of a mid-septal placed electrode in PR and LAO angulation. With the mid-septal stimulation, we do not achieve a normalization of the QAS complex. However, as in this example, we can achieve a narrow QAS complex. The better way would be to do direct stimulation of the His bundle. If it is possible to stimulate the His bundle directly without exciting the surrounding myocardium, we speak of a selective His bundle stimulation. If the surrounding myocardium is stimulated together with the His bundle, we speak of a non-selective His bundle stimulation. I did my first His bundle stimulation at the end of the last century. The X-ray shows the position of the atrial electrode and the His electrode. In 2000, Deschmuck published results with the His bundle stimulation. He described feasibility of permanent His bundle pacing in 18 patients with dilated cardiomyopathy, chronic and atrial fibrillation, and normal QAS and a V-node ablation. He was successful in 12 patients with a pacing threshold of 2.4 volts and an R amplitude of 1 to 3 to millivolts. The left ventricular ejection fraction improved from 20 to 30%, and he had 2 dislodgements. Long operation and fluoroscopy time and a success rate of only 50 to 60% prevented a breakthrough of this therapeutic method in these times. That changed with the development of special delivery sheets and electrodes. The first performed sheets came from Medtronic together with a thin electrode, the 3830, who is placed over the sheet without a guide wire. Now steerable sheets are available, and all companies provide delivery sheets and his bundle leads. Let us start with a case report of a his bundle stimulation in a patient with a PR prolongation. A 65 years old male with recurrent dizziness, dyspnea class 2, ejection fraction 64%, no cardiac, no coronary heart disease, paroxysmal atrial fibrillation and sinus bradycardia with an first degree AV block and a second degree AV block. The problem with this rhythm constellation is that DDD stimulation leads to permanent right ventricular stimulation, and algorithms for reducing RV stimulation do not work here. In the first position, we have a nearly normal QRS complex, but the his bundle stimulation is not selective, visible in the ECG by the small delta wave you can see here that follows the stimulation artifact. In the second position, a little more cranial than the first, there's a selective his bundle stimulation with an isoelectric line between the stimulus artifact and the QRS complex. In an intra-individual comparison, Keen determined the hemodynamic effect of the 3 stimulation mode in patients with PR prolongation: his dual chamber pacing, pacing avoidance algorithm, and RV dual chamber pacing. As you can see, the best hemodynamic results are found in his DDD stimulation, while RV stimulation decreases the systolic pressure compared to the avoidance algorithm. On the right side, you see the effect of an AV delay optimization that is possible with his DDD pacing. When a prolonged AV delay, with a prolonged AV delay, you have a fusion of the A and the E wave in the mitral valve Doppler. By optimizing the AV time, the A and the E waves separate, bringing the A wave close to the ventricular contraction, in this way reducing diastolic mitral regurgitation and improving cardiac output. In patients with HFrEF and AV node ablation, his bundle pacing normalized the ejection fraction over time, here more than 3 years, whereas in patients with HFpEF, there is a slight increase in ejection fraction and no decline, as it is typical in RV pacing. In the case-controlled study of Abdelrahman, all patients required initial pacemaker implantation between 2013 and 2016 were included. Permanent his bundle pacing was attempted in consecutive patients in one hospital and right ventricular pacing at a sister hospital. Implant characteristics, all-cause mortality, heart failure hospitalization, and upgrades to biventricular pacing were tracked. Primary outcome was here the combined endpoint of death, heart failure hospitalization, or upgrade to biventricular pacing. 765 patients were included with a mean ejection fraction of 54% and a mean follow-up of 2 years. There was a significant decline of the combined endpoint in all patients under the His bundle stimulation. The second study of VI Araman showed the long-term clinical outcomes in 192 patients over 5 years. The ventricular pacing burden was 56%, and the combined endpoint of death and heart failure hospitalization was only significant in patients with a ventricular pacing rate of more than 40% here on the right side. Also, these studies probably contain overlapping collectives. Sun published a meta-analysis of these 2 studies. Heart failure hospitalization was significantly reduced under His bundle pacing, while all-cause mortality shows a favorable trend. The new guidelines rate the evidence of His bundle pacing and pacemaker indication only as a level C. And given a 2B indication only in patients with an ejection fraction more than 40% who are anticipated to have more than 20% ventricular pacing. Coming to His bundle pacing in left bundle branch block. High performed a detailed intracardiac mapping of left septal conduction to assess the presence of level of complete conduction block in the His Purkinje system. A left intrahesian block was assessed in patients, it was found in 46%, and a QRS correction by pacing was possible in these cases in 94%. In 16%, in 18%, the block was localized in the left bundle branch, of which 62% QRS correction was feasible. In 36%, the block has a distal location without a possibility of QRS correction by pacing. So in 2/3 of the patient with left bundle branch block, it is possible to have a stimulation over to correct the left bundle branch block with His stimulation. In the next case report, I show you a 56-year-old male in UR class 3 and an ejection fraction of 28%. He had a left bundle branch block with a QRS rise of 172 milliseconds. The intracardiac electrogram over the pacing electrode, I show you here, showed His potential and the left bundle branch block. In the picture in the middle, you can see the stimulation site below the block. Stimulation from this point results in a short QRS complex. The 12 lead ECG in top gives you the picture of selective His bundle stimulation with a QRS duration of 90 milliseconds and a pacing threshold of 0.75 volt. In another patient with His bundle stimulation and correction of the left bundle branch block, you can see the same effect of resynchronization as we saw in the beginning video with biventricular pacing. In mapping studies, Arnold compared intrinsic unpaced QRS left bundle branch block with His bundle pacing and biventricular pacing. In left bundle branch block, we have the latest activation in the lateral wall of the left ventricle, that is the blue color. His bundle pacing shows the narrowest QRS complex with the most homogeneous activation of the left ventricle. Here's the green color. while biventricular pacing showed a right bundle branch morphology in VI and an inhomogeneous activation, the red and the green color. There is one prospective randomized study comparing his bundle stimulation with biventricular pacing in left bundle branch block, which is unfortunately limited in its scope and the high rate of crossover. Compared with biventricular CRT, the on-treatment analysis showed a higher reduction in QRS duration, a better rate of echocardiographic response, and a greater change in left ventricular ejection fraction in his bundle CRT. In a long-term follow-up study, his bundle pacing showed a stable increase of ejection fraction over time. But this has a price in a high stimulation threshold of average 2.3 volt up to more than 3 volt. The new ECG guidelines therefore recommended in CRT candidates in whom coronary sinus lead implantation is unsuccessful, a class 2A indication for his bundle pacing. Beside his bundle pacing, a new procedure was developed, left bundle branch pacing. The site suitable for direct stimulation of the left bundle branch lies below the bifurcation. It can only be reached by penetration of the septum. Huang first described the effect of left bundle branch pacing. On the left, you see a left bundle branch block with a QRS duration of 165 milliseconds. On the right side, a stimulated QRS complex with a QRS width of 104 milliseconds. A successful left bundle branch pacing results in a right bundle block configuration with a small QRS complex. In the middle, you see the his bundle pacing lead, which lies below the his bundle lead. You see the left bundle branch pacing lead, which lies below the his bundle pacing lead and is penetrating the septum. The follow-up over 6 and 12 months showed an increase in ejection fraction and a response rate of 75% in normalizing L function after 12 months. The same working group recently published a comparison between his bundle stimulation, left bundle branch pacing, and biventricular pacing. The highest reduction in QRS duration was observed under his bundle pacing and left bundle branch pacing. His bundle pacing and left bundle branch pacing showed higher ejection fraction improvement and a greater response rate than biventricular pacing. So let me conclude. To avoid pacemaker-induced cardiomyopathy, do not stimulate from the right ventricular apex. That's a simple message. His bundle pacing could be an alternative for patients with PR prolongation, permanent atrial fibrillation, and a V-node ablation, and in patients with pacemaker indication and an expected high ventricular stimulation rate. In patients with heart failure and left bundle branch block, biventricular CRT have been demonstrated to relieve heart failure symptoms, reduce mortality, and improve clinical output. Conduction system pacing, like his bundle pacing and left bundle branch pacing, could be an alternative for patients with heart failure and ventricular dyssynchrony, especially when effective biventricular CRT is not achievable. But his Purkinje system pacing demonstrates promising results, but there are no randomized control